I hope you've been having a good time at this Congress. What I'm going to be giving is a tutorial trying to explain a complex system that's very important for everything. And I just came from a beautiful lecture by Luigi Cappalala from St. Thomas's in London describing how prone positioning can cause cardiac output to go up or go down in ARDS completely due to heart-lung interactions. Okay, so what I'm going to do is make it simpler. And I've got a confession to make. I have been lecturing on this title for a little over 40 years. So I apologize if some of the slides are old, but as a couple of people said, Dr. Pinsky, is what you said before still true? And I assure you that if things have changed, I'll show you the new data to support it, because the one thing I follow is heart-lung interactions. Okay? My conflicts of interest have really nothing to do with this. We think about ventilation and cardiovascular stress. In terms of the cardiovascular stress side of it, you may consider that spontaneous ventilation is exercise. And as such, just like a COPD or a heart failure patient can't walk up 2 flights of stairs, if the work cost of breathing is too hard, they can't breathe without a ventilator. Spontaneous breathing also, relative to apnea, increases the amount of blood within the chest, filling right and left ventricular volumes, which is called preload, and it impedes left ventricular ejection, which is left ventricular afterload, goes up. Positive pressure breathing does the exact opposite. It decreases preload and unloads the left ventricle. So let's go through these things. It's that simple. And if you understand those, you actually don't need to stay. Okay. Ventilation is exercise. And you and I, if I were to measure the oxygen consumption of your body in a relaxed state, and then I put a CPAP mask on you to decrease your spontaneous breathing, I couldn't measure the change in oxygen consumption because it is so mild. And that's what it should be, because you're breathing to get oxygen in and to blow out carbon dioxide. And it would be really stupid for the body to make the exercise that does that, it consume a whole lot of oxygen on its own. Unfortunately, lung disease and cardiovascular disease of pulmonary blood flow markedly impair the efficiency of oxygen delivery. And if the oxygen work of breathing increases because of either shunt, dead space, or stiffness to the lungs, you'll get a significant inefficiency of gas exchange, and oxygen consumption by the lungs may become now a major determinant of oxygen consumption by the body. The number of studies that over the literature have shown that breathing is exercise is too numerous to count. If you read a chapter in a textbook that I wrote on heart-lung interaction, there are about 60 references I show. That's also it. It's no big deal. But what I really like was a study by Dr. Zev Masinifar at Cedars-Sinai, in which he measured gut perfusion of patients with COPD that are on ventilator, and he showed that if you look at them at baseline before they're going to wean, and they successfully wean, here shown in green but beforehand, and then you look at what happens after they wean, their gut perfusion remained normal. And that's what you'd expect to see in a normal person. But then he looked at the people who were going to fail, and he didn't know they were going to fail beforehand, he just was measuring it. And he found that even though that was in the normal range of gut perfusion, it was statistically significantly different. And furthermore, when they were on spontaneous breathing for 20 minutes, they developed a degree of gut hypoperfusion, that's equivalent to cardiogenic shock. Okay. In fact, Amal Gibran showed that if you take patients with chronic obstructive lung disease who cannot increase their cardiac output to meet the increase in metabolic demands of the body, the only way they can maintain oxygen consumption is to increase the arterial venous O2 content difference, which you know is increasing extraction, and you see therefore that the mixed venous O2 sat falls in failure to wean patients. So, ventilation is exercise. Spontaneous ventilation may be so much exercise that the body can't do it, and mechanical ventilation may be the way to improve gas exchange, not by increasing oxygenation, but in the setting of a fixed shunt in the lung, allowing mixed venous O2 sat to rise, and therefore for the same gas exchange, you'll have an improved oxygenation. Okay? Well, if it's exercise, I can use it as an ECG stress test, just like putting them on a bicycle. And the number of studies that have shown that spontaneous breathing from mechanical ventilation induces cardiac stress. This is really the big fish. Okay? This was a nice study that was done by Francois Lemaire with Jean-Louis Touboul and others many, many years ago, 88, in Paris, in which they looked at a series of patients with chronic obstructive lung disease that were on mechanical ventilation. They were going to wean them off the ventilator. And this is a slide that was handed to me by Francois Lemaire after presenting his abstract on this at ATS. So this is the original data. And I want to show you in this one patient a few things. First of all, this is baseline on mechanical ventilation, 5 minutes and 9 minutes of spontaneous breathing. As you see, there's an esophageal pressure measurement, a pulmonary occlusion pressure. And as you can see, the esophageal pressure dips down then rises, so that's probably a triggered pressure ventilation. So this is a person's on ventilation, they triggers the ventilator, it goes poof. Okay, and when that happens, you see a slight increase in pulmonary artery occlusion pressure, and the mean end expiratory pressure in this patient is about 5. Intrathoracic pressure is normally -2 as I'm standing up here, but when I lie supine, the chest and the heart go down on the esophagus, and 5 is a pretty normal end pleural pressure in that setting. Now let's look at what happens when he went to 5 minutes of T-tube trial. The esophageal pressure at end expiration, which is the lower one here, becomes more negative at end expiration because the patient is holding their lungs open more. Okay? And when they take in breaths, there's profoundly negative swings in intrathoracic pressure of 20 millimeters of mercury, minus 20 millimeters of mercury with every breath. Have you ever seen that in a patient? Yeah. And what that did was it markedly increased pulmonary artery occlusion pressure from 18 to 42. That's real. And it's not a decrease in transmural pressure relative to pleural pressure because pleural pressure went down. That's a real increase in intrathoracic blood volume. By 9 minutes in this patient, the respirations were becoming agonal. He was up to 50 millimeters of mercury. And I asked Francois, what happened at this point right here? He said, I put the patient back on the ventilator or he would have died. Said in another way, this is not subtle. If you put a person on a weaning trial, do not leave the bedside. You will know in 5 minutes if they can wean. If they fail to wean acutely, it's cardiovascular. If they fail to wean chronically, it's because of retained secretions. You actually are liberated from the ventilator. So the hemodynamic effects of ventilation, now let's talk about them specifically. They're due to the changes in lung volume, because every breath has to change lung volume so that you can breathe, and changes in intrathoracic pressure. Both spontaneous breathing and positive pressure breathing increase lung volumes. So the lung volume changes may be similar in those two. The difference between spontaneous and positive pressure breathing is not the change in lung volume, but the change in intrathoracic pressure and the energy necessary to produce that change. Well, let's first talk about changes in lung volume because it's really important. The lung is richly innervated with parasympathetic and sympathetic tones so that every time you take in a breath, there's a change in your sympathetic and parasympathetic tone tonically. Okay? And you know this because every time you breathe in, your heart rate goes faster. That's called respiratory sinus arrhythmia. God only knows why. My guess is they want your heart rate to be faster because when you breathe in spontaneously, there's more blood in the chest, and that allows you to get more of a cardiac output, which is a good thing. But I don't know. God didn't tell me, and I didn't ask. However, there's also a change in pulmonary vascular resistance, which I'll show in a second. And then if you have very long, large lung volumes, you'll squeeze in the chest, and I'll show you that too. But let's talk about the pulmonary vascular resistance first. In the body, pulmonary vascular resistance is directly altered by two things. One, if the alveolar, P big A O2, falls because of hypoxia, not hypoxemia, or the pH of the blood goes down much below 7.2, the pulmonary vasculature vasoconstricts in that area. And that is called hypoxic pulmonary vasoconstriction. And this is important because if it's in a local area, it allows blood flow not to go to an area which I'm not ventilating, and it improves the ventilation-perfusion match. As the lung volumes increase, it also increases pulmonary vascular resistance, zoning out the lungs, but I'll describe what the zoning is in a second. And finally, the autonomic tone changes as well, and that half of that is due to sympathetic tone. The other half is due during deep inspirations to release by the vascular endothelium of prostacyclin. So you basically are causing vasodilation with every breath. So in the body, in the lungs, we have the pulmonary vasculature from the pulmonary artery through the capillaries to the lungs passes through a region of the lung which doesn't see pleural pressure as its surrounding pressure. It sees alveolar pressure, and those are the alveolar vessels. The alveolar vessels are a very, very small amount of vessels, but they surround 100% of the alveoli, and that's the business end of the gas exchange. They see as their outside pressure, alveolar pressure. All the other vessels see pleural pressure as their difference. What is the difference between alveolar and pleural pressure called? That's your transpulmonary pressure, right? So, with every breath, the transpulmonary pressure must increase. Yes? You remember pulmonary physiology? That's a true statement, okay? Every breath, transpulmonary pressure increases, and therefore with every breath, there's an extra luminal pressure gradient that's getting bigger. If you were to look at the relationship between lung volume and pulmonary vascular resistance, and you had from residual volume, RV, to functional residual capacity, to total lung capacity, you would see that as many things in life, it's a U-shaped curve. The lowest pulmonary vascular resistance that we have is where we functionally live. And as lung volume gets smaller and smaller, pulmonary vascular resistance goes up. And if lung volume gets bigger, pulmonary vascular resistance also goes up. But it goes up for different reasons. If you look at the alveolar resistance, alveoli have no vasomotor tone, they're capillaries. But as the transpulmonary pressure exceeds at index inspiration the difference between pulmonary artery pressure and airway pressure, you progressively decrease the perfusion of pulmonary vascular beds. And as the cross-sectional area of the capillaries decreases, capillary resistance goes up because you're perfusing less vessels, right? That's a very simple concept. I've just described to you west zone of the two, never once mentioning left atrial pressure, okay? So the larger the lung volume, the greater the alveolar resistance, the smaller lung volume, you don't have to sweat it. What about the extraalveolar vessels? Well, they have the exact opposite effect. At really high lung volumes, when you hold in your breath, you not only have larger airways with lower airway flow resistance, but you also have large vessels because the same radial forces holding open the airways is holding open the blood vessels. But as you go down smaller and smaller below FRC, the terminal bronchi close down, and as they do, the distal airways are not being ventilated, and you progressively deoxygenate them. And by the process of hypoxic pulmonary vasoconstriction, your pulmonary vascular resistance goes up. So pulmonary vascular resistance goes up in both cases, but for opposite reasons. Hakim and others showed beautifully that as the alveoli collapse, you get hypoxic pulmonary vasoconstriction. And Roy Brower, before he did the ARDNS survival tidal volume, when he was a younger fellow at Johns Hopkins, showed that the opposite is true. If you overdistend the lungs, you collapse the alveolar vessels. Okay? So if that's true, this gives me a physiologic rationale for PEEP. Positive end expiratory pressure can only increase end expiratory airway pressure, right? That's all it does. That's why it's called positive end expiratory pressure. So if I have a patient with normal lungs, I'm going to overdistend them if I give an increase in transpulmonary pressure. That should increase pulmonary vascular resistance. So I would tell you, don't give people with normal lungs high PEEP. It's not good for them. But if you recruit lung units and open up alveoli, you should decrease pulmonary vascular resistance. So Canada, from Bill Sybil's lab, looked at an animal model in which they took lungs, and in half of them they gave oleic acid lung injury to one lung, and the other half they gave oleic acid lung injury to the other, but they all have the same pulmonary artery and pulmonary veins and the airways. So the only thing they were looking at was changes in transpulmonary pressure, and they just asked the question, was the effect of progressively increasing PEEP from 0, ZEEP, to 5, 10, 15, and 20 centimeters of water on pulmonary vascular resistance? They looked at a lot of things, but this is what I'm going to show you. And as you can see in the damaged lung, left or right, at baseline, pulmonary vascular resistance was really high because of the acute lung injury. And as they gave PEEP, there was an immediate decrease in pulmonary vascular resistance, which stayed from 5 to 10. And this is almost assuredly a reversal of hypoxic pulmonary vasoconstriction by recruitment of alveoli. But as they went further, after the recruitment was done, further increases in PEEP increased pulmonary vascular resistance. What happened to the normal lungs? Well, at baseline, the pulmonary vascular resistance of that was a third of what it was in the injured lung, okay? As you'd expect. You want all the blood flow to go to the healthy lung. And as you add a little bit of PEEP, there was a small but statistically significant decrease in resistance, probably because of reversing microatelectasis, and that's why we tell you to give 5 of PEEP to every ventilated patient. But after that, as you can see, you overdistend the lung and it goes bigger. But look, there's no difference between lung injured and normal lungs. Once they're overdistended, they have the same increase in pulmonary vascular resistance if you overdistend them. That's why you recruit the lungs, but don't over-recruit them. And hyperinflation is really, really common. As Pepe and Marini showed years ago, if you have a person with COPD that's breathing on a ventilator really hard, low cardiac output and blood pressure, if you simply pop them off ventilator and have them not anything at all, you see the esophageal pressure falls, the wedge pressure falls, but you're not hyperinflated, so the true filling of the ventricles goes up, pulse pressure rises, and cardiac output goes up. Okay? So one of the main reasons that happens, independent of hyperinflation, is that the heart, when you expand your lungs, the chest wall can go out, the diaphragm can descend, but the heart is trapped in the cardiac fossa and gets compressed inward, 100% analogous to tamponade. And we see this in severe COPD and status asthmaticus as well. And to prove it, I want to show you a pretty picture of a person who was given 10 of PEEP, and they were put in a CT scanner, and you're seeing on the top 0 PEEP, the lungs at end inspiration and end expiration. And I want to show you, as you go from 0 to 10 of PEEP, the lung volume collapses down. The heart volume collapses down. This ain't rocket science. Okay, look how little the preload is at 10 of PEEP in a healthy, normal person. Okay. So let's now talk about the effects of intrathoracic pressure on hemodynamics. But to do that, you have to accept a hypothesis. And that hypothesis is that the heart is in the chest. Do you accept that? Okay, then we're good. The heart is in the chest, a pressure chamber inside a pressure chamber. Therefore, increases and decreases in intrathoracic pressure must affect the pressure gradient for venous return to the heart and left ventricular ejection from the heart, independent of the heart itself. Right? Well, let's look at it. To look at it, let's first look at systemic venous return. And as you probably recall, if you're looking at a ventricular function curve with right atrial pressure versus flow here, and we now look at the opposite side, that's your right ventricular function curve, but we say, what about what's happening to the blood coming back to the right ventricle? We see that we have an opposite shaped curve. It's a negative slope, and when the pressure in the right atrium equals the pressure in the periphery, we have no pressure, and that pressure is called mean systemic pressure. And what it means from this venous return curve is there exists one and only one point, which we call the equilibrium point, that says that every patient, and you included, has only one cardiac output and right atrial pressure you can have at baseline. But the heart is in the chest, and when the heart is in the chest, with every positive pressure breath, it pushes the this pressure on the venous return curve was this extrathoracic. To the left, if you're breathing positive pressure, to the right was spontaneous, this side over here, if you're spontaneous, that's left, and that way if it's right. So let me show you real data from an intact pig that I took in 1984. Raise your hands if you were not born in 1984. Come on. Okay. So I can comfortably tell you, we knew this before you were born. This is an intact chest in which I opened up the chest, put pericardial balloons, and put a flow probe on the pulmonary artery and closed the chest up. And this is a pleural pressure falling, so that's a spontaneous breath. And this is a pleural pressure rising, that's a positive pressure breath. You will note that as the pleural pressure fell, CVP decreased, causing stroke volume to go up because of the increase in venous return. Remember, we shifted to the the left. And with the positive pressure breath, we caught a small increase in right atrial pressure, impeding venous return, causing right ventricular stroke volume to go down. Okay? So this is the effects of positive pressure breathing. If we look at that same picture I showed you before, with the positive pressure breath, remember, CVP went up, but cardiac output went down. See that? CVP went up from here to here, but cardiac output went down. Okay? Now, there's no change in ventricular pump function. But what patients do who are put on a ventilator, or if you're taking care of them and they're unstable, is you give them a volume infusion, gives them a new mean systemic pressure, and nicely they're back to where they should be. Okay? The problem is that let's assume they're nice and stable on a ventilator and you want to extubate them. Well, Francois Lemaire already showed you that if you take them off and they have really strains, they'll then fill their blood into the lungs and their wedge pressure will go up to 40 and they will die. So if you're going to extubate a person who's on mechanical ventilation, make sure they're dry when you extubate them. Number 2, never extubate a hemodynamically unstable patient. The lungs aren't your problem at that time. Don't make them a problem. Okay? So how does this work? With the positive pressure breath, there's a fall in vena cava flow, a subsequent cause of fall in pulmonary artery flow, and finally a fall in arterial flow, as it basically goes from venous return to the right ventricle and out. Okay, and the top one is the cause of pulse pressure variation that we use for hemodynamic monitoring to predict volume responsiveness. And as we showed in this study, if you progressively increase the tidal volume from 5 to 10 to 15 to 25, which you would never do, and you looked at what happens to the blood in the chest from beat to beat, looking at the difference in the stroke volume of the right ventricle to the left ventricle, you see that with inspiration, positive pressure inspiration, the volume in the blood in the chest falls, and it falls greatest with the greatest tidal volume, and it comes back during diastole, during an expiration. And furthermore, as Andre Deneau showed in our department, he's now a senior critical care doctor in Montreal and is lecturing at this meeting. I'm very proud of him. That if you then look at a human being in the operating room and you have an automated border detection of an echocardiography, you can see clearly that the left ventricular preload goes down as well after about 3 beats, because it takes that long for the blood to get over to the other side. And in fact, what this happens if you're looking at left ventricular pressure volume loops, that the heart compresses and gets bigger. Okay? And that's the pulse pressure variation that you know. So positive pressure ventilation was created as a way of keeping people alive when they were critically ill. But there's nothing good about it other than the fact that it decreases the work cost of breathing, maintains the airway open, and allows you to get a stable amount of oxygen. It is bad in every other way for ventilator-induced lung injury and cardiovascular effects. So to the extent that you can avoid positive pressure breathing in your patient will be better. Regrettably, there's a lot of patients, whether we like it or not, that need it. So understand that the effects on hemodynamics will be profound. Let's go the other way. Here we go. Venous return. I'm sorry, we did this one. One of the other things we found is that in patients after surgery with a lot of fluid on board, we would give them PEEP and their cardiac output wouldn't fall. And that was because as you gave them PEEP, you descended the diaphragm and their intra-abdominal pressure rose, raising mean systemic pressure. And therefore, the cardiac output didn't fall half as much as you thought it should for the increase in right atrial pressure. Said in another way, having an intact abdomen, especially if you have a bit of ascites, it saves your life. So guess what happens if you take a patient in the operating room who has hypertension, intra-abdominal hypertension, and you open the belly? What happens immediately? They become hypotensive. Immediately. Okay? Because you've lost that stenting of the mean systemic pressure. And if you're the anesthesiologist or the intensivist talking to the anesthesiologist, say if you're going to open this person's abdomen, make sure you got a big line in and be ready to give fluids really fast. They don't need vasopressors, they need fluids. Okay? So now let's go the other way. Increases in intrathoracic pressure, increased transmural pressure. And that's really hard to explain, so I'd rather show you a picture of my children. This is, down here on the left is my daughter Stephanie, who, by the way, is the mother of 3 now. So this is an old picture. This is the oldest, Daniel. And this is the youngest one, Jill, who's a real troublemaker. She's a master's in engineering and crime, straight up walls. Okay. Do you care how tall my kids are? Or how high their head is above the water? It is their height of their head above the water, which is their transmural pressure. So it really doesn't matter what their height is. What you care about is how high is their heart above the water. So what you care about is the pressure in the heart relative to the pleural pressure. So, many years ago with Andy Buddha in Stanford, we thought this through, and this was actually a drawing I put on a napkin that we simply made into a figure in the New England Journal, in which I said, let us assume that this box is your chest, and this crescent here is the left ventricle. And let's assume the pressure inside the box is 0 and the aortic pressure is 150. You would all agree with me that the transmural pressure that the left ventricle had to eject against is 150 millimeters of mercury, correct? That's nothing special about that. So let's now take an example in which we give phenylephrine, a pure alpha agent. And you should never use phenylephrine except if you need it just for touch once or twice in the operating room. Otherwise, norepinephrine is a treatment of choice for hypotension in the operating room as well as the ICU. But we use, in this example, a pure alpha agent. And let's just make arterial pressure 200. You would all agree with me that the transmural pressure has increased to 200, correct? There's nothing secret here. But what if we've had a person breathe in against an occluded airway, which is called a Mueller maneuver? And the one thing that you can do with your lungs is suck. You have an amazing ability to create negative intrathoracic pressure. You're not too good at blowing because you can only go a certain way, but boy, can you bring in air. So I can make the pleural pressure very negative. And if I made it minus 50 and the arterial pressure on the top was still 150, I would have the same 200 millimeters of mercury increase in afterload. Said in another way, every time you breathe in, the negative swings in intrathoracic pressure are equal to an instantaneous increase in left ventricular afterload. Recall Francois Lemaire's patient that every time they breath went in, he had a minus 20 fall in pleural pressure. That's an increase in afterload by 20 millimeters of mercury with every breath. Okay? So we showed in this first study that decreases in intrathoracic pressure increase left ventricular ejection pressure, increasing afterload, and positive pressure breathing later we showed unload the left ventricle. This is a picture from the original paper, and it's still true, that if you looked at the strain phase of the inspiratory pressure, you see that the end-diastolic pressure rose. So you'd expect you've pulled all this blood on the heart, but at the same time, the ejection fraction and the stroke volume all fell. So if this is the case, if I were to do positive pressure breathing, I'd reverse this. So what if I gave positive pressure to a heart failure patient? Well, that'd be like giving nitroprusside. I'd be decreasing venous return, but I'd be improving left ventricular ejection. So that would cause the venous return, the curve to kick this way. But if I improve left ventricular ejection because I was in heart failure, I might see cardiac output go up. Well, that's exactly what we saw. If you look at the change in stroke volume with a jet ventilator, so there's no tidal volume, from apnea, and then you go to slightly increases in airway pressure, you see that the intrathoracic blood volume decreases, the pressures fall, because you're giving positive pressure. But if you notice, the trope volume goes up. So positive pressure increases the heart. Decreases in intrathoracic pressure will help as well. So if this is true, it's hard for me to sustain an increase in intrathoracic pressure. But any relative increase in intrathoracic pressure should decrease left ventricular afterload. So if I abolish the negative swings in pressure seen because of forced inspirations by intubation or something like that, I should immediately abolish left ventricular afterload. And the number of studies that have shown using CPAP for acute cardiogenic pulmonary edema or bronchospasm or upper airway obstruction immediately is reversed, the pulmonary edema is immediately reversed, is too numerous to count, and it's totally due to heart-lung interactions. So in summary, as the work of breathing increases or cardiovascular reserve decreases, it may be impossible to breathe spontaneously. And this is the most common cause of failure to wean from mechanical ventilation. It's either too much work of breathing, too little cardiovascular reserve, or a combination of the two. Failure to wean from mechanical ventilation is often due to cardiovascular insufficiency. Spontaneous inspiration spontaneously increases intrathoracic pressure, and if you're in a patient with the poor ventricular function, it can induce acute pulmonary edema. Positive pressure breathing may reverse these negative swings and be beneficial, but if you're hypovolemic or a trauma patient that comes in and you put in a ventilator and you don't give them fluids first, it's a good recipe to call a cardiac arrest because they need volume. When you do positive pressure breathing, you will all be decreasing intrathoracic volume. And with that, I thank you for your attention.